which we use in our everyday basis. Not a day goes by without sending a culture or reading a culture report in ICUs. So why culture is important? Why do we send cultures? Nowadays, as we all know, we all face antimicrobial resistance as a global threat, which is going towards, it is a great burden to our antibiotic stewardship program. But the whole of the antibiotic stewardship program is targeted towards early narrowing of the antibiotic which we prescribe to the patients, and early de-escalation. For all those perspectives, we need these culture reports so that we can narrow down those. A culture and sensitivity report provides information on the type of microorganism which is present in a sample, and then their susceptibility to various antibiotics. So sample can be withdrawn from various sites of the body. It can be blood, urine, respiratory tract, skin, bone and joint tissue, bone and joint infections. In that case also we collect samples, CSF and stool. Before going through the interpretation of the culture sensitivity report, we should all know interpretation not only goes only reading the culture reports and starting the antibiotics. It starts since the patient arrived in the ICU. Whenever patient is arrives in the ICU, we have to evaluate what are the clinical symptoms, and do we suspect sepsis in that patient. If at all that is there, the timely collection of samples for identification of the organism is very necessary. I will go through brief points about different sites, how to collect culture reports. Culture samples, like for blood cultures, it is very important to collect at least 2 sets of the culture samples. For that, one site should be peripheral and one should be central. Whether if central line is present, then second sample should always be drawn from that central line. And not only that, we have to, after getting the culture report, we have to identify or differentiate between contaminant and true bacteremia. If one culture grows a likely contaminant organism, then we should repeat the cultures always. If multiple samples grow the same organism, then true bacteremia is usually the result. Likely contaminants of the blood sample collection, while we collect the blood sample through venipuncture, then likely contaminants are gram-positive like Staph epidermidis or Corynebacterium species. But even in the patients who are immunosuppressed, in those conditions, these can also present as true bacteremia. Only one positive culture is needed. Only one positive culture is needed to suggest true infection in patients with gram-negative bacteria, which is detected. Gram-positive bacteria that is associated with true infection include Staph aureus or Streptococcus pneumoniae. In respiratory cultures, there are various methods to collect the specimens. It can be collected through sputum, through endotracheal aspirate, or through tracheal aspirate via through bronchoalveolar lavage. Presence of when we read the sputum or any respiratory specimen reports, there is always one heading of epithelial cells. It signifies how much contamination is present in that sample. If epithelial cells are more than 10 per low power field, that represents contaminant sample. In that case, we have to resend the sample. And for detecting whether it is true infection, if we collect the specimen through protected specimen brush, then colony counts more than 10 to the power 3 colony forming units indicates infection. If we collect through bronchoalveolar lavage, more than 10 to the power colony forming units are signify infection. For endotracheal sample, it is more than 10 to the power 6 PFU. Am I audible clearly? Then we go through urine culture. Urine samples, before collecting urine, we all know urinary tract infections are always primary infections. They are never secondarily attributed to any other infection. So timely urine sample collection is very important. If urine routine microscopy shows more than 10 WBCs or pus cells, as we say, per low power field, that signifies UTI. But that is not only the sole criteria. For that, we have to wait for culture sensitivity as well as clinical symptoms of the patients are very important. Urinary tract infections can be symptomatic or asymptomatic. That can be catheter related or non-catheter related. First, I will go through slides to define what is UTI. So, as I already said, urinary tract infections can be symptomatic or asymptomatic. In symptomatic urinary tract infection, it is the COTI guidelines that I will go through it. So, symptomatic urinary tract infections is divided into 2 parts, SUTI 1A and 1B criteria. In 1A criteria, patient must meet 3 conditions. First condition is patient should have indwelling catheter in place for more than 2 calendar days, or at least a day prior to the collection of culture sensitivity report, or the same day of the culture sensitivity report. You get it? I'll repeat it. Patient had an indwelling catheter that had been in place for more than 2 consecutive calendar days in an inpatient location, or on the date of event. Date of event means on the date of sample collection, or it should be present for any portion of the calendar day on the date of event, as in date of sample collection, or it was removed a day prior. Even if the catheter was removed a day prior to the sample collection, it is considered as catheter associated urinary tract infection. Second criteria is patient should have at least one of these following symptoms. Symptoms are fever, dysuria, urgency, frequency, suprapubic tenderness, and costovertebral pain or tenderness. And third criteria, which is culture directed, is patient has a urine culture with not more than 2 organisms detected, and at least one of them should have colony count of more than 10 to the power 5 CFU. Okay, so this if these 3 criteria are fulfilled, then it is considered as catheter associated urinary tract infection. And what do we mean by indwelling urinary catheter? That should pass through urethra into the bladder and should be collected to an external valve. That means if we are talking about suprapubic catheters, that doesn't come under this CORTI criteria. Okay. SUTI 2 criteria. This was SUTI 1A. 1A is catheter associated. Then we move forward to SUTI 1B criteria. In 1B criteria, patient has or had indwelling urinary catheter, but it has or had not been in place for more than 2 consecutive days, or it was removed more than 1 calendar days prior to the sample collection. That means the criteria which were getting fulfilled in type 1A should not be there in 1B. Or patient should have symptoms in this, like same symptoms: fever, dysuria, urgency, frequency, suprapubic tenderness, and costovertebral angle tenderness. And third criteria, culture directed, is also same. That what was that criteria? Detecting not more than 2 organisms, and at least one of them should have more than 10 to the power colony frequency unit. SUTI 2, symptomatic urinary tract infection 2 criteria, has all the above findings, but it is detected in patients less than 1 year of age. So in those patients, first criteria is patient is less than 1 year of age. Second criteria is patient has at least one of the following signs and symptoms, which are fever, hypotension, bradycardia, apnea, lethargy, vomiting, or suprapubic tenderness. And culture criteria is same in this also. One type of UTI is also which is non-symptomatic. We call it asymptomatic bacteremic urinary tract infection, ABUTI. For that, all culture criteria is same. Apart from that, we get one of the sample of the urine should be same as we have got in the blood culture report with more than 10 to the power 5 colony forming units. If that criteria lies, that is called as ABUTI, asymptomatic bacterial urinary tract bacteremic urinary tract infection. This was for urine. Now, what are the steps in bacterial identification and withdrawing? We have already withdrawn the samples now. Now we will just analyze the bacteria. First step is identify the microorganism. In that it comes gram stain, so that we understand the morphology of the bacteria. It is whether it is gram positive or gram negative, whether it is cocci or bacilli. That gives us a rough idea of the probable organism which we are suspecting in the patient. So this is a small chart to, as we all know, gram positive bacteria, gram positive, if we are informed that gram positive cocci is there. So we all know it can be staphylococcus or streptococcus or enterococcus. If it is gram positive bacilli, it can be Corynebacterium or Listeria. Gram positive coccobacilli consists of Haemophilus or Campylobacter, Kingella, Echinella. Anaerobes, Actinomyces, Clostridium. These are gram positive anaerobes. When we talk about gram negative cocci, these are Neisseria, and gram positive bacilli are 2 types. These are either lactose fermenters or non-lactose fermenters. Among lactose fermenters, we get E. coli, Klebsiella, which we commonly get in our settings. And in non-lactose fermenters, it can be Pseudomonas, or if we get Coccobacilli in that, it can be Acinetobacter. And gram negative anaerobes consist of Bacteroides and others which Now, after gram stain, we have methods of culture sensitivity testing. Culture sensitivity testing contains two types of methods: conventional and modern methods, newer methods, molecular methods. First, we will talk about conventional methods of identification of antibiotic susceptibility testing. The samples which contain bacteria are exposed to different culture media for 24 to 48 hours for any bacterial group. Those bacteria are then identified using direct microscopy, and these isolates are then transferred to different media containing antibiotics. When the bacteria gets killed by those antibiotics, that is how we apply different methods to detect sensitivity of the organisms. There are a few conventional methods: disk diffusion or Kirby-Boyer method, broth microdilution, agar microdilution, e-test or automated systems are there. I will talk in small, very few slides are there for them. This diffusion method or Kirby-Boyer method is very common conventional method used for bacterial identification. In this, what we do is we apply a disc containing antibacteria to a culture plate where bacteria is growing. This antibiotic then diffuses out of this disc gradually. What we expect is whenever the antibiotic diffuses out of this disc, its concentration gradually decreases with the diameter, and the area where least concentration of the antibiotic, where the growth of the bacteria gets inhibited, there we draw a circle with that diameter, that is called zone of inhibition. How do we read it? If the bigger the zone of inhibition, that means lower the MIC and more the susceptibility of the bacteria for that organism, for that antibiotic. Am I clear with it?
Yes.
Next is, so zone of inhibition I have already told you. Next method is microdilution method. In this, what we do is the antibiotic is diluted in like 1/4 dilution, then 1/6 dilution, then 1/8 of the dilution, and it is then placed in different test tubes or different wells, and then bacteria culture is exposed to those dilutions, and the minimal dilution at which the growth of the bacteria gets inhibited is called the MIC, and the more and it doesn't get inhibited, that means bacteria is resistant to that antibiotic. I'll read also. The broth microdilution method involves placement of serial dilutions of antibiotics in wells containing a sanitized inoculum of the organism. The minimum inhibitory concentration is then determined as the lowest concentration of the antibiotic that inhibits the visual growth of the microorganisms after serial dilutions. These are two types, broth and agar dilution. Difference between broth and agar dilution is that in broth dilution, we put antibiotics in different wells, small wells containing these antibiotics, and then bacteria is exposed with different dilutions of these antibiotics. And in agar dilution, we keep, this is liquid media. In agar dilution, we keep these different dilutions of the antibiotics, and then so that particular dilution will test with antibiotic. One advantage of broth dilution is we can test multiple antibiotics at the same time for the same organism. This e-test is combination of both. Here, one test tube contains liquid media with diluted sample of the antibiotic, and that plate consists of bacteria along with diluted sample of another antibiotic, the same antibiotic, and the area of intersection determines the MIC. Automated systems are more advanced systems. They are a combination of technologies such as colorimetric or fluorometric assays and standardized inocula, and then they determine MIC values. And the example of these are Vitek 2, Microscan, Walkway, Phoenix, and Sensitire. I'll come to this slide again. So interpretive criteria of culture sensitivity are established by regulatory agencies such as Clinical and Laboratory Standard Institute CLSI standards or EUCAST. This is European Committee on Antimicrobial Susceptibility Testing. The criteria defines the susceptibility, intermediate susceptibility, and resistance categories for each antibiotic and microorganism combinations. For this, we have two words. One is MIC and one is breakpoint. First, I will go through those two words. Breakpoint is established by regulatory agencies to categorize bacteria as susceptible, intermediate, or resistant. That means this is a particular concentration of antibiotic particular concentration which is determined by those agencies on the basis of pharmacokinetic and pharmacodynamic properties of the drugs and how much concentration that achieves in the blood. And breakpoint is the particular point below which if MIC lies, that means that antibiotic is susceptible and that bacteria is susceptible to that antibiotic, and if above which that MIC lies, that means that is resistant. Intermediate is the word which is used because for the same, if we increase the concentration or if we increase the time of exposure of particular antibiotic for some organism and it gets killed, then it is called intermediate. MIC comes below breakpoint. Below breakpoint, any concentration, minimum concentration which is achievable at the source of infection and it kills the bacteria, then it is minimum inhibitory concentration. Both these points are clear to you people, MIC and breakpoint. Is there any doubt No? So antimicrobial susceptibility testing, just one aspect of the decision making process for appropriate antibiotic therapy. Other factors such as severity of the infection, patient's immune status and pharmacokinetics of the antibiotics must also be considered before prescribing the antibiotics. Consider the type of sample which is taken and then we will see the penetration of the particular antibiotic which is sensitive to that organism, whether that is penetrating that part or not, penetrating to that sample or not. Consider the patient's clinical condition, medical history, whether he is immunosuppressed, he is immunocompetent or so, and then interpretation of antimicrobial testing results should be done in conjunction with clinical judgment. Some antibiotics may fail to achieve a cure in the clinical setting, in vivo settings, but despite showing susceptibility in the laboratory. Why so? Because there are various reasons for that. Resistance mechanisms, because what we are dealing with is nowadays is the rapidly developing resistance patterns in all the organisms. Toxin productions, pharmacokinetics and pharmacodynamic properties of the drugs, right? So limitations of culture sensitivity reports are in vivo and in vitro variation, pharmacodynamic and pharmacokinetics need to be considered. Prolonged all these process from sample collection till the final sensitivity report, it takes total 4 or 5 days. In gram staining we get earlier, then we get a provisional report, then we get final report. This whole process takes 5 days. So this is long time. Then does not account for the presence of mixed infections. It doesn't tell us whether it is contaminant or true infection. It does not, and some gene resistances are not identified. Some gene resistance nowadays we are getting identified by different tests. Different tests have been developed to detect the gene resistance patterns. I will enumerate few. These are rapid diagnostic tests so that we can reduce this time of sample collection till the detection of the organism, so that early antibiotics should be started. These are MyVit-Off, PCR, multiplex PCR, PNA-FISH, BioFire. We must be using. Every one of us must be using. Common resistance patterns which we detect in ICUs are ESBS, extended spectrum beta-lactamases producing enterobacterials. More commonly, AMC types of resistance among this is CTXM15, which we detect in our labs. AMC, which is difficult to detect. Carbapenem resistance enterobacterials, we also face these challenges. Then we can send for gene studies so that we get different patterns of resistance like KPC, NDM, oxacillinases, VIM. Difficult to treat Pseudomonas is also one which we get. Methicillin resistant Staph aureus, MECA gene which is involved in that, or VRE enterococci. So steps of interpreting culture report. In general, I will go through 4 points before in steps of interpreting the culture report. First is identify the microorganism. We go through the culture report, we will read which microorganism is there. Then determine the level of susceptibility which is shown in the culture report from which drugs it is susceptible and for which it is not. Then consider the source of the sample and the clinical condition of the patient, and then use this information to select the most appropriate antibiotic. Then, and after that, last and which is not least, evaluate the quality and completeness of the report. As I said already, if a sample is already contaminated, it will give you false positive results. So follow up with the microbiologist for additional information, because there are always few information which is hidden to microbiologist only, and we have to contact microbiologist if we want some extra sensitivity to be detected. This is one example of tracheal aspirate. I'll just, it will be a questionnaire. This is tracheal aspirate, which is growing Pseudomonas aeruginosa, right? And as you can see, it is sensitive to many drugs. So my first question is which antibiotic will you prefer?
Ceftriaxone.
Nah, yeah, Ceftriaxone. Is it in Pseudomonas?
For Pseudomonas, we have many groups of drugs which has intrinsic Pseudomonas susceptibility. Those groups are penicillins also, cephalosporins. Among cephalosporins, we have third generation cefoperazone and this ceftazidime, which has intrinsic Pseudomonal activity. Fluoroquinolones are all sensitive. Carbapinons are sensitive, and aminoglycosides. These all cover these have Pseudomonal activity. Our first step should be always start with beta lactams. Is there any beta lactam sensitive in this culture report?
Pip.
Yes, ceftazidime sensitivity is there. Piperacillin, this is penicillin. Penicillins also have intrinsic Pseudomonal activity in this piperacillin, tazobactam and ticagrelor. These both drugs have Pseudomonal activity. Here we can see sensitivity towards piperacillin and tazobactam is there. So first drug of choice should be penicillin or any beta lactam antibiotic. Okay. We reserve carbapinons or fluoroquinolones for infection because these have tendency to get resistant, developing resistance. In difficult to treat Pseudomonas organisms, we will add these. Then we after getting the sensitivity report, and we have seen this is sensitive, this is resistant. Then we have to go ahead with pharmacokinetic and pharmacodynamic data and how much is the penetration that I have already explained. Then we always know, microbiologist always knows the better. If we want to convert it to some oral formulation, if we want to get some other sensitivity, we have to ask microbiologist. Another question. This is blood culture report, which is showing Enterococcus faecalis. What will we start in this patient, or any other information you want? As we can see, this is
Can be source of
sample is blood.
Can be a contaminated sample.
This is vancomycin sensitive Enterococcus, right? This is not vancomycin resistant. So my first step again, always start with beta lactams. Is there any sensitivity? Yes, ampicillin is sensitive, right? And ampicillin has good coverage for blood infections.
Yes,
so we will start with ampicillin. Okay. And one more important thing is, do not compare MICs between the drugs. When you decide which antibiotic has to be, here we can see MIC, in this sensitivity report. Few drugs have MICs of less than 1, few drugs have MIC more than 30, 32.
Yes,
This should never be compared, because MIC is different for different drug and it is meant for that drug only. Here we were. And here also, the microbiologist always knows better. If we want to add oral formulation of this vancomycin sensitive Enterococcus, then we have to ask microbiologist whether he has tested linezolid sensitivity. If yes, then we can. That is the only oral formulation which can be added for Enterococci, right? This is one urine culture report. This I wanted to show you because this urine culture is showing Klebsiella pneumoniae, okay, and it has shown sensitivity to various drugs, including there is in front of CB5 you can read it is written extended spectrum beta lactamase. It is written already there, right? So we know that ESBL E. coli is there in urine. Accordingly, we will add antibiotics. But in some laboratories, they are not testing ESBL. Then how will you determine whether this organism is an extended spectrum beta lactamase or not?
This is a very important question in the accountability.
Because not all labs test ESBL.
Anyone would like to attempt? These culture report, this is one culture report which you will very frequently encounter. And many reports, as Shalini mentioned, do not mention that it is a ESBL. So just looking at the sensitivity,
Here it
how
is
do you
mentioned,
diagnose?
but you won't get it every time. Third generation cephalosporin. Okay, and yes.
this would use like
Any quantitative thing you want to add?
They are also resistant to parvovirus.
biophenol.
Yes, please. One thing, so I'll tell the answer. For detecting whether the organism is ESBL or not, we have to look at the ceftriaxone sensitivity along with its MIC. If ceftriaxone is resistant along with MIC of more than 2, then it is considered as ESBL organism. Okay, then we'll deal with as ESBL organism and treat accordingly.